Well, all right, everyone. Welcome back to the Dr. Alex Show. And today we're going to talk about seizures. And seizures tends to be not a white elephant, but just something that is hard to address. It can be very defeating. And when it comes to working with them, from our perspective, I hope everyone finds it refreshing because there is a lot that can be done to help to reduce the seizure activity, increase functionality, learn what your triggers are at the core to keep them down, and overall just improve one's health and vitality. And I may or may not be able to go into specific conditions. There are hereditary-based conditions. There are forms of epilepsy that have strong genetic components. There's forms that do not. Then there's seizures that are not at all even called epilepsy, which I'll distinguish out. And then there's even what we call pseudo epileptiform activity, which is where I live as a functional neurologist. So we'll see where we go with this. But what I want to do is talk about the different types of seizures and what's going on in the brain, and then about what we do with it from a functional neurological perspective. So when it comes to, let's just go up to this term called epileptiform. So it sounds a lot like epilepsy, and epileptiform just means too much brain activity. And under that umbrella, this epileptiform umbrella, we have the true epileptiform activity, and then under that is called seizures, and then epilepsy. And then the other branch of this tree, this diagram, if you will, going down, that I drew myself this morning on my computer, is pseudo epileptiform activity. So with epileptiform activity, we can have seizures. And this is where a lot of people in the general public understand what seizures are and what could be going on with them because they might know someone, they might have seizures. So with that, just going into the different types of seizures, let's talk about first partial seizures and then complex seizures. So I'm going to be peeking from my camera to my notes here just to make sure I hit everything because it's a lot. And personally, working with seizures isn't anything that Dr. Lauren and I market. It's not anything that we discuss a lot. Whenever someone comes in with them, it's a lot of fun for us because it's a good change up from what we usually get to see. And with that, it's easy to forget about the subtle nuances like the difference between a simple partial and a complex partial seizure. So just getting a bunch of nerdy stuff here. But when it comes to these partial seizures, going over here, we have these simple partial seizures, and these are oftentimes maybe called, for right or wrong, called focal seizures or absent seizures. But with these simple partial seizures, the patient is aware, so they know something's going on. So if it's like a motor-based seizure, let's say your hand just starts to move on its own randomly, not a tremor. Tremors are usually slower, but let's just say it's a very quick, jerky movement. And maybe it's not even a myoclonic jerky motion for everyone else out there who knows that term. Then we're talking about a seizure, and let's say this is my right hand and it's just shaking away. Then we're talking about a seizure most likely in the left motor strip of my frontal lobe, so the left motor strip. If it's more of a sensory-based seizure, maybe it's going to be excessive tingling on that right hand again. Maybe everything checks out. Let's say that right hand is just tingling away, like it feels like I just slept on my hand all night long, and it's not numb, but it's tingling away. And there's no peripheral nerve entrapment anywhere. impinging the entire hand, because there's 3 major different nerves that innervate and give sensation to the hand. So there's no peripheral entrapment. There's no brachial plexopathy, so brachial plexus entrapment. There's nothing going on with the neck. There's nothing anywhere else. MRIs, everything come back clean. It's just coming back that, man, this hand is just tingling away. That could be a seizure in the left sensory strip. Maybe there's autonomic seizures. Actually, we have a patient in currently who's one of her legs, sorry, she only got 2 legs, sorry. Her right leg and on the front side of her upper thigh gets goosebumps, randomly just gets goosebumps. Nowhere else. It will get goosebumps with her other leg if it is a time to get goosebumps, like from being cold. Otherwise, this patient will get goosebumps down her thigh, and we're still getting it figured out because we've only been in twice. If this is actually a issue where, yes, it could be a autonomic based, like a reflexogenic based seizure, or is this coming from more of a peripheral issue because we have a history of having a entrapment issue from a tumor in our pelvis that can actually push on the peripheral nerve that gives rise to the sensation of that leg. So that'd be a good example of like an autonomic one. Psychological seizures, those are where people can be not only hallucinating, but they can be even making up scenarios in their head, and it looks and walks and talks and can even smell a lot like someone is having some sort of personality issue, but it comes and goes just like a regular motor or sensory based seizure, pretty quick. Then we go into these complex partial seizures. This is where people don't have awareness. Again, these can be these almost like what looks like an absent seizure. Not as common that I get to see. And then we go into what's called a partial seizure, which goes secondarily into what's called a generalized seizure. And this is important because people can have these partial seizures where it's like you end up having some sort of seizure in one area of the brain, and then it just kind of grows like a wildfire into not having any awareness, but you can have convulsions, and it just kind of spreads, unfortunately, like a flower just blossoming, not the flower that we want to blossom. Then we move over to the other type of seizures, and this is where people generally have their minds go when it comes to seizures. So the big daddy here under complex seizures is generalized, tonic-clonic, unconscious with convulsion seizures. This is where you might see people, or I've heard of people, just dropping, hitting the floor. They're convulsing. Their eyes are rolling in the back of their head, or it will look like they have this nystagmus. Their eyes are just beating, going everywhere. There could be fluid coming from their mouth, like saliva, even a little bit of foam, due to the autonomic response. And then they can even have some urinary incontinence issues. They might actually urinate all over themselves because of this. That's what people typically think of. And that tonic-clonic generalized seizure, that's what they used to call grand mal. So that term gets thrown around still, but it's not a technical term anymore. The powers that be, decided to get together and name it tonic-clonic just to confuse everyone, I think, and get rid of the grand mal name. So then the other more common one, and this one's really important for kiddos with attention issues, is absent seizures. So with absent seizures, this is a situation where you'll have kids that, or adults, sorry, but let's just focus on kids for a sec, because you could have a kid that just stares off into space. Just nothing. And it looks like they're spacing out, mouth open, mouth closed, moving a little bit, maybe not moving at all. And it will look so much like attention problems. It'll look like ADHD. But it's not. Don't get me wrong, they could have ADHD, but absent seizures, every once in a while we'll have a kid come into our office and they fit pretty much the bill for ADHD. They kind of toe the line with some things like maybe impulsivity, but overall it just doesn't seem right. And it ends up being that they actually have these absent seizures. And the thing is with these absent seizures, they could come out of it with a little bit of a, hey, are you listening? Or some sort of stimulus. And it doesn't necessarily last long. Sometimes these absent seizures will last. I've had them up to close to a minute. Other times it could just be seconds at a time. And that's something to keep in mind if you got a kiddo or working with anyone that is just not improving and it looks a lot like ADHD. Maybe it's this absent seizure situation going on. The other one when it comes to complex seizures is myoclonic jerks, or what a lot of people look like, just they're performing these jerking movements. Like it'll just be like an arm will just out of nowhere. And it's a big, gross motion. It's very quick, but it is not just this like repetitive hand motion that's very quick, because it's the entire limb, and it's not a tremor because again, a tremor is going to affect the distal part of the limb, and it's going to be slower. They have a slower frequency. So with these myoclonic jerks, this can happen pretty much with every limb. It can go on with the neck. It can almost look at like a form of dystonia at times, but it's actually seizures. And that part of the motor strip, that part of the brain that tells us to move our body, just, hey, go, is seizing. It's just firing off. Then the other one is like a close cousin called clonic jerks, and that's more repetitive, but again, not as slow as a tremor and not quite as fast as what'll be like a very quick, again, like almost like a hand motion. Then you have the tonic part, which is where someone's going to be just stiff and rigid, and you can't move them when they're in the middle of it. You could pick them up and they're like stiff as a 2x4. Or the person could be atonic. They have like a loss of muscle tone. So they're just kind of like a limp noodle. So then with all of this is where I want to go into what's going on with seizures. We have all these different forms, different things that happen. Well, if you're not very aware of what seizures are, the thing is all of this is extra activity in the brain. And to make activity in the brain happen at the lowest level, you have to have a bunch of electrolytes move into a neuron and then move out, and that causes it to fire, makes it do something for us. Well, that extra what's called electrolyte gradient or sodium gradient, it's just going off, firing. And with these seizures, it's using up all of this electrolyte gradient activity, if you will, and firing over and over and over and over again for no apparent reason. And it's spontaneous, and it can be random. And if it happens over and over and over and it's really out of rhythm, then that's called epilepsy. But if it happens, but you don't have any of the epileptic correct waveforms on an EEG, then it's not epilepsy. Then you just have seizures. But what it is doesn't matter where in the brain. It's all extra brain activity. Too much brain activity is going on, and it's causing the excess symptoms, if you will. So you have these people that have excessive arm motions or leg motions or head motions or neck motions. Maybe they have weird sensations. I mean, it could feel like they have water running down their back for no reason, and they're nowhere near water. They could have these odd autonomic symptoms, again, the goosebumps thing, or legs feeling cold or hot. There could be fevers involved. We can have loss of consciousness, no loss of consciousness, and it's all because the brain is firing off in that area or in general way too much. So then when this happens, most of the time we have positive symptoms, like we can see limbs moving or the body doing something. Or sometimes we have negative symptoms. And sometimes if someone is having a seizure, they might have what's called arrest of speech. Fancy way of saying they don't talk. And that's because Broca's area in the brain, fun little trivia fact when you're at your bar trivia, Broca's area is what is used to speak. So I'm using it right now, obviously. And if there is epileptiform activity in Broca's area or seizure activity in Broca's, and it's firing way too much, you will have most likely arrest of speech. You will not have speech. You'd think it'd like speed up, like the person would be able to like rap or something when they couldn't. That'd be cool in a way, but no, it's actually going to cause the area to shut down most of the time. So when we have all this extra activity, where our minds go when the person comes in office is, okay, what can we do to calm it down? And we'll go into that after. I think what we're going to do is try to focus this show on some of like what goes on with seizures and what triggers it, and then go into treatment in another show here. So the next little part of looking at epileptiform activity is what we call pseudo epileptiform activity. Well, I guess let me go back to epilepsy real quick. So epilepsy means the person has the seizure over and over and over again, like variable frequency, but it is going to be fairly frequent. We're talking multiple times a week. And this can come from genetic mutations. It can come from genetic mutations with not only some global neuronal function, but particularly it goes back to this real nerdy electrolyte gradient channel activity here, because we have to have sodium go into a neuron to make it do something for us, and then potassium to leave it. Sodium in, potassium out. That makes neurons fire. And you have to have a channel to let the sodium in and let the potassium out. So people can have these genetic issues, these mutations that are going to cause malformations or something wrong with that channel, not allowing sodium in there appropriately or allowing it too much and then potassium out at the appropriate levels as well. And there's other situations, and I'll be honest, when it comes to more the nasty situations, like almost like the word's leaving me. It's almost like a microdysgenesis, I believe is the term, where it's like a neuronal migration complex issue where the brain actually absolutely changes. That's like pure pathology. I think I pulled that way out of the deep recesses of the hippocampus, and I couldn't even tell you after that what that is, but I know that microdysgenesis, I believe, is involved with seizures, and it's something that I'll never see, and I hope I never have to see, because it sounds very nasty. Basically, the brain completely changes, and it's not fun. So God bless anyone that has to deal with that or anything along those lines, because I'm not sure what could be done there. So epilepsy recurs over and over and over again. But let's go into this pseudo epileptiform activity. And this is where I think a lot of people can get mixed up, especially in the world of doing your own research. So nowadays we got access to everything. Google AI, WebMD. Does WebMD have AI now? I mean, like we were just talking about it before we got rolling here. There's nothing wrong with doing your own research. Patients come in well-educated. It's just there's always more to it usually, and we have to clarify some things with this. And people will come in with what's called pseudo epileptiform activity, and it means that their neurons are firing because the brain is not healthy. We're talking about inflammation. We have mitochondrial-based issues. We have hypoxia issues, glucose dysregulation problems, and we can have problems that look, walk, and talk and smell a lot like a partial seizure, like someone, again, like hands going numb or something like that, or tingling, and it's all because the brain's actually just not healthy. So those areas of the brain could be very, very all out of whack and all out of sorts, because again, we can have inflammation rolling through there. Maybe we're not eating right, so we're not feeding our mitochondria the healthy antioxidants that it needs, along with stable glucose or even ketones to be able to work appropriately. And it can just look a lot like, again, seizure problems, but it's not. And it could be something as goofy as like an abdominal spasm. Someone could think like, hey, this was a good example. An individual, he comes in, very fit firefighter for a local department here in the metro. He can do just about anything with his body, but he ended up having these abdominal spasms. And then also with that, he would go to the bathroom 5-6 times a day, non-forming liquid stools. This went on for decades. Well, it just gradually got worse and worse because what was going on was he had non-epileptiform pseudo epileptiform activity in the motor strip of, particularly this was his right motor strip in the area that represents his abdominal wall. And with this situation, that area of his motor strip was firing off for no reason, but there wasn't seizure activity. He even went and got EEGs, 24 hours, stayed in hospitals, all of it. So nothing was going on, but it was overfiring. So that was going on, and when that was going on, it eventually, in my theoretical hypothesis here, led to a reflexogenic response, because that information of the firing of the abdominal wall musculature, there's feedback information that goes back into the spinal cord up to the brain, telling the brain what's going on. That information will fire in to the spinal cord, and then some of it could be back out, and it could go back out reflexogenically via the same nerve roots, because some of those nerve roots are dealing with actually digestion. So he'd be pushing things out of his abdomen that don't need to be pushed. So when that was occurring, over time he was losing he was having a lot of electrolyte loss. So he'd end up going, and by the end of the day, he'd be very dehydrated. He'd be drinking a lot of water and eventually just be going to the bathroom way too much overnight. So what's interesting about this case is it was pseudo epileptiform, and you're probably like, Dr. Alex, what'd you do about it? Well, one, we're chiropractors for crying out loud, so we adjusted him. We did that to calm down his nervous system, because getting adjusted does just that. We worked on his vagus nerve to calm down his nervous system. But then we did only one thing at a time. So those two things calmed him down, but it didn't change really any of that. It just got him to be less anxious about it, which is great. Then I put a laser on his right motor strip where the abdominal wall is represented. It's about kind of halfway down your brain, in line with your ear. So right about like here, if you like drill a hole in my head, right about here, we'll hit the part of what's called the homunculus, where that abdominal wall is. And I put my laser on there on infrared for anti-inflammatory purposes, and that started bringing the spasm down, which was so cool. So as the spasm went down, his stools started to change. He would not go as often, but we still weren't forming. So then sounds counterintuitive, but started giving him electrolytes. So he didn't have seizures, but you would think, like, why would you still give him electrolytes when we're talking about having the sodium go into these neurons and you're feeding the beast? Well, in this case, he didn't have seizures. We're not dealing with the sodium and the potassium getting utilized too often and inappropriately. We're actually dealing with electrolyte loss because he'd be losing so much fluid throughout the day through his feces. So what we did is we gave him his electrolytes, gave him anti-inflammatory protocols with the laser, and then over time he started to form stool. And life got busy, and it was kind of a non-dramatic end. He started forming regular stools. He'd go maybe 3 times a day, which is really what we want anyway, and haven't seen him since. And I told him, y'all firefighters are busy, because what happens with them is they work, and then a lot of times they have second jobs or third jobs, and then they like have the audacity to coach their kids like t-ball team. It's just, they're crazy. So I said, if it gets busy and I don't hear from you, I'm assuming it's because you're good. And if you're not good and you go a long time without not being good, you might get a little backhand when you come in, because we could have nipped it in the butt sooner. So I assume it's good. But that's a really good example of pseudo epileptiform activity, and it responded so well with our Shed Light cold lasers, of course, a sponsor of our show. Shed Light cold lasers from Dr. Griswold. If you are a practitioner or if you are lay public, you can buy these lasers, the same lasers that we use in office, and you can use them for just about anything for your health needs. And that's exactly what we did on this gentleman to help out him, to help correct his issue. So with the pseudo epileptiform activity, that's a lot of what we see, because it's this gray, weird area that medicine doesn't necessarily have an answer for. They don't know how to deal with it. They're just not trained in it. Yet, at the same rate, it can look a lot like seizure activity. So when it comes to seizures, I think what we'll do is kind of end the show with, it is excessive activity. Brain is on fire, firing way too much, whether it's a focal point of the brain or generalized. We can have full-blown tonic-clonics, what used to be called grand balls, all the way down to maybe just I have tingling in my hand and that's it, and that could be seizure activity. It really runs amok. They can be caused by genetic issues. They can be a little bit more hereditary based, but not a hard genetic mutation problem. In the world of neurodevelopmental disorders, you can have them very frequently with rare diseases. So you can have these genetically caused diseases, like in past shows that we've talked about, especially with our beloved Christian family, with little Isaac. And he can be very susceptible to seizures. That could be an example where he can be susceptible due to his genetic problem. But his genetic problem has nothing to do with necessarily causing seizure activity, but it causes brain issues which could lead to it. So with genetic issues, it's fairly common, just kind of across the board, whether it's directly related to the functionality of these channels that let sodium and potassium out, or something along those lines with brain function, or if it's just like, again, with our little beloved Isaac, he has a genetic issue that deals with his thyroid hormone. He could be susceptible at any point with seizures. And it could be any of what we just talked about. Tonic-clonics to more focal seizures, or absent seizures, or even partials. So it gets a little dicey in understanding it, but what's cool is there's a lot of information on how to break it down and understand it from a parent standpoint or from a patient standpoint. I think next show we're going to go into what can we do more about with these seizures. So I'll see you guys next time. All right, everyone. The Dr. Alex Show is brought to you by Shed Light Cold Lasers. Shed Light Cold Lasers is, bar none, the biggest thing that has changed our practice at HML. Not only
on a professional basis and the results that we are getting with our patients, because for all the professionals out there, everything from veterinarians to medical doctors to everyone in between, you can use this laser in your practice for just about anything. But on a personal basis, because what's unique about this laser is it is handheld. And if you know anything about cold lasers, a lot of times they're big, they're gaudy, you almost have to bolt them to a wall and you can't take them anywhere. This one you can take anywhere. That's because the diodes are LED, so it runs on really good lithium-ion batteries. And the other awesome feature about this, if you know anything about lasers, is that you can kind of see it on camera there. This laser has red light and infrared light. So we won't go into the details there, but just know that you got all of those features. It also comes preloaded with all of the presets to work on specific organ systems, to work on different areas of the brain, like our specialty at HML, as well as a whole host of other things that you can do with this laser. And to learn more about the lasers, head on over to shedlightcoldlasers.com, 518-338-6658, or you can email Dr. Griswold, or Griswold as I call him, shedlightinformation@gmail.com. And we want to note that you don't have to be a doc to buy these. You can be a patient, someone off the street. And Shedlight specializes in educating professionals, doctors, therapists, as well as lay public people, if you will. If they want to buy a laser, they will completely educate you on how to use it, or they will send you to a doc on the ground, someone like us, to learn how to use it, or they'll just send you to that doctor's office, and then you can let the doc take over. Either way, they'll give you all the knowledge and information and resources you need to either get that laser or where to find one in the doc's office.